All right, I'd like to introduce Dr. Economos. She's a graduate of Downstate Medical School. She's currently the director of Gynecology at New York Presbyterian Methodist Brooklyn. That's what's called? Some combination of those names. So I welcome her. She's going to speak on ovarian cancer.
Good morning, everybody. Just make sure I got my controls. Okay, so I'll spend the next hour talking about ovarian cancer. My slides have basically remained unchanged for the last several years, basically because the core didactics stay the same. And at the end, I'll go over some of the changes, exciting changes that we have in the treatment of ovarian cancer that were a long time coming. So just to give you an idea of the scope of the problem, the number of 21,000, if you remember 21,000 in your mind, pretty much that's going to be the statistic that you can count on, because that has changed very little over the years, maybe a couple thousand here or there, but basically 21,000 cases a year, considered the 6th most common cancer in women in the United States, but the 2nd most common of the gynecologic cancers, endometrial cancer being the most common. And in general, it's about a 1.5% lifetime chance of developing the malignancy in the lifetime of an American woman. Of those 21,000 incidence cases, we've got 16,000 deaths annually, also a pretty steady number over the last few decades. And it stays at the 6th most common cause of cancer death overall for women. But it is the most common cause of death from a malignancy of the female organs. So it is the most lethal of all. And you have probably about a 1% lifetime risk in the United States, if you're female obviously, of dying of ovarian cancer. So these statistics have pretty much stayed the same for the last 40 years. The age of onset in American women, if you look at what the peak incidence occurs at age-wise, it's usually in the mid-60s. But most of the cases occur, especially the epithelial types, occur after the age of 40, and that would be 80%, and 30 to 40% occur after the age of 65. So while we do have a good number of women in their 40s, developing ovarian cancer, you can see here that the majority of the patients are going to be in their 60s or even 70s. Of course, you know that there are many different types of ovarian cancer. It's not one size fits all. And even within the subtypes that I show here, there are DNA differences that really distinguish ovarian cancer as a very multivariated, histologically speaking, pathologic entity. But we do classify them into 4 major categories. Epithelial, meaning starting in the cuboidal epithelium that lines the surface of the ovary. A so-called epithelial cancer accounts for 90%. Germ cell tumors, which arise in the oogonia, or the eggs of the ovary, and 5%. Stromal cell cancers, the hormone-producing granulosa or theca cells account for 4%, and there's different types, carcinosarcoma, metastatic to the ovary, those account for just 1%. So clearly the most common is the epithelial type, and when you hear about ovarian cancer in the lay press, this is usually in reference to the epithelial type. Of those epithelial types, the categorization is serous, 50%, endometrioid type, 25%. Those are related to history of endometriosis, mucinous, clear cell, and then the Brenner tumor is the rarest. So what causes ovarian cancer? There's some simplistic theories that are starting to be teased apart, indicating how different ovarian cancer really is under the microscope. But in general, there are 3 main etiologic categories: reproductive, environmental, and genetic factors. So at the base of the pathophysiology, the basis of the pathophysiology of the development of ovarian cancer, the epithelial type, is that of incessant ovulation. And we came to regard this as a possible etiology because of the factors that we identified that are known to reduce the risk of ovarian cancer. And those factors still hold today, despite new advancements in the understanding of ovarian cancer. And that would be multiple parity, history of breastfeeding, oral contraceptive use, and bilateral tubal ligation. Skipping over now to environmental factors, those include consideration of external carcinogens that gain access into the female peritoneal cavity. If you think about it, the female peritoneal cavity is available or accessible to the outside world. So that makes for the theory that there may be some sort of external environmental agent that gains access into the peritoneal cavity, to the surface of the ovary, and that would be, especially in the light of these recent lawsuits implicating the use of talc down by the vulvar area where the talcum powder particles would gain access into the vagina, through the cervix, through the endometrial cavity, through the fallopian tube, and come out and splatter onto the ovarian surface and cause the irritation, if you will, the irritability of the epithelium that leads to DNA changes that eventuate into an ovarian cancer. And really a very kind of out there kind of theory, but it has been implicated enough where it's now gained traction in the courts. But it really highlights this accessibility of the ovarian surface to environmental carcinogens, which also brings in the bilateral tubal ligation story, which is how if you do a BTL in a woman, it affords approximately a 40% reduction in the risk of developing ovarian cancer. That is starting to evolve in understanding more the contribution of the distal fallopian tube or the fimbriated end of the fallopian tubes, pathophysiology and the development of ovarian cancer, where maybe it's not so much of the interruption of the passageway, as it were, to the peritoneal cavity by tying off the tube, but maybe more of interrupting the blood supply at the distal tube that leads to the eventual carcinogenesis in the fallopian tube that then infects the ovary secondarily. So these are theories of pathophysiology that are still evolving, and we're going to be figuring it out, I think, within several years. Other environmental factors that come into play, other than the consideration of the access to the peritoneal cavity by environmental carcinogens, is the dietary factors. It's unclear exactly what dietarily may be contributory to the development of ovarian cancer, but there have been reports that implicate retinol and derivatives in the prevention of ovarian cancer. There's been implication of lactose consumption in the development of ovarian cancer. But basically, there are very sparse data implicating other dietary factors that might be prevalent in the American diet that would increase a woman's risk for developing ovarian cancer. But we suspect that there's some dietary contribution only because of migration populations that come from other countries with a low ovarian cancer prevalence who develop ovarian cancer in this country. So there is some consideration of diet. Then there's genetic factors which loom large lately with the explosion of all these genetic testing panels that we have available to us, next generation sequencing and such. And clearly things like a positive family history are going to increase a woman's risk at baseline. As I mentioned before, your general population risk of developing ovarian cancer in your lifetime in the United States, if you're a woman, is about 1.4%, about 1.5%. When you have an affected first-degree family member, your lifetime risk increases to 5%, and 5 to 10% of ovarian cancer cases are thought to fit hereditary pattern of autosomal dominant inheritance. That number has been now increased to more close to 15%. So I would say 10 to 15% of ovarian cancer should be considered possibly hereditarily derived. And the hereditary syndromes that currently have been identified is the well-known breast and ovarian cancer syndrome related to the BRCA1 and BRCA2 genes. These are tumor suppressor genes, and they also help in the repair of DNA. BRCA1 is located on chromosome 17. BRCA2 gene is located on chromosome 13. So impairments of these two genes impair and sequence the production of proteins that are involved in DNA repair. And if that is a faulty mechanism, that leads to the development of ovarian cancer cells. There's also ovarian cancer participation, if you will, in the Lynch 2 type syndrome, or the hereditary non-polyposis colorectal cancer syndrome. We know that's mostly colorectal, as it says, and endometrial cancer, but ovarian cancer is part of that syndrome. So what are the features when we take a formal history from a patient, including a good family history, that leads us to suspect that there may be a likelihood of a BRCA mutation, which in turn should prompt us to, if we are not able to test for BRCA mutations in our own offices, send the patient to a genetics counselor so that can be done. Multiple family cases of ovarian, breast, or both cancers in successive generations, obviously on the same side of the family. A red flag is when you hear of a woman having had either breast or ovarian cancer under the age of 40, certainly under the age of 50 for breast cancer, but even more pointedly if it's under the age of 40. If there is a history of breast and ovarian cancer in the same, if the patient herself has had both of these cancers, at this point, any ovarian cancer, personal incidence of ovarian cancer, or a history of personal ovarian cancer is a signal that there may be a BRCA mutation and should be tested. Bilateral breast cancer in the patient herself or in a family member. Male breast cancer is a red flag for BRCA mutations and Ashkenazi Jewish heritage. The link between ovarian cancer rooted in the BRCA mutation increases your lifetime risk of getting the other BRCA mutation, the other BRCA-related cancer, or if you're not affected yourself, your family history alone will increase your risk of developing either of the BRCA-related cancers. BRCA cancer, 50 to 85% lifetime risk. Usually these women develop it at an early age. You have an increased risk for a second primary breast cancer if you have the BRCA mutation, 40 to 60%. You have a 15 to 45% risk of developing ovarian cancer if you carry the BRCA1 mutation. And there is also suspected increase in the risk of developing prostate or colon cancer. Those have not been quantified as such, but these are the increased risks of developing these cancers otherwise if you have the BRCA mutation, BRCA1 specifically. BRCA2 carriers also have an increased risk for certain cancers. Again, it's breast cancer, stays the same, 50 to 85%. This is where male breast cancer is more visible. It's a 6% chance of developing male breast cancer when you have the BRCA2 mutation. So patients who hear about the breast cancer, ovarian cancer risks think that the mutation, BRCA2 specifically, has only a problem related to females, but it's obviously a problem for males as well. Male breast cancer is well below 1% in general. Here it's 6% risk if you carry this mutation. Your ovarian cancer risk is a little bit less if you're a BRCA2 mutation carrier, 10 to 20%. But you have an increased risk of prostate, laryngeal, and pancreatic cancers. Again, the magnitude of this risk has not been identified, but they are associated with BRCA2 mutations. So how do you manage BRCA mutated patients? And first of all, you have to be mindful of their families. Other adult relatives have to be tested. Basically, their siblings and their adult children. If they have young children, usually testing is thought to be best started at the age of about 25, to not screw up their psyche, so to speak. And then if they are positive, these young people, they have to start increased screening soon after that. Other things that you need to tell your patients who are BRCA mutated, that they have to have some lifestyle changes, more exercise, less processed foods. Chemo prevention would be something that may be appropriate, tamoxifen to avoid breast cancer. And then the one that you would probably be most surgically involved with, which is to perform prophylactic or risk-reducing surgery. That would be the laparoscopic prophylactic bilateral salpingo-oophorectomy. And what it does by removing the adnexa in the woman is you eliminate the risk of primary ovarian cancer, but you have to be mindful to also report to them, although it's it's reported as high as 10, 11% primary peritoneal cancer in BRCA mutated patients who have their ovaries taken out. It has not been my experience. I've had one patient who had this maybe over the last 20 years among the ones that I've done risk-reducing prophylactic BSOs laparoscopically. But you have to mention to them that they can still develop an ovarian cancer-like malignancy that arises in the peritoneum. Laparoscopic oophorectomy clearly is a more surgically preferable procedure, in terms of approach, because of the lesser surgical morbidity. Be mindful again that you're going to induce surgical menopause. Be prepared to be able to handle the complaints that the patient will have, especially if she's 35, 40. And we still don't have long-term data on the BRCA mutated patients in terms of their mortality from all causes. That's been expounded on in the recent literature addressing the issue of BSO in women under the age of 45 who have increased risk of mortality, morbidity, and mortality from all causes, mainly cardiac. We don't know whether these patients subscribe to that statistic or not, but probably they do. When should we offer prophylactic oophorectomy, especially in women in the United States now that are deferring their childbearing until later years in hopes of maybe advancing their careers or finding the appropriate family situation or getting married, and all those social interferences are making childbearing be deferred later and later. This can be a problem in patients who carry BRCA mutations because the median age of sporadic ovarian cancer we know is 63, but the median age for ovarian cancer and BRCA mutated carriers, mutation carriers, is younger. And by the age of 40, 17% of patients develop ovarian cancer, and by the age of 50, 33%, or a third of the BRCA mutated, that would be 1 and 2, develop ovarian cancer. I should say it's more 1 than 2. The 2 maybe a little bit later, closer to 50. But certainly the BRCA1 mutated patients, a third of them have already had a cancer developed by the age of 50. So the optimal time to perform the risk-reducing prophylactic laparoscopic BSO is before the age of 40, even at the age of 35, if they've completed their childbearing. Now, I should mention here, and I'm sure you all have heard more and more about the implication of the distal fallopian tube, the fimbriated end that is in the pathophysiology of the development of ovarian cancer, which has arisen from the study of all these specimens that have been submitted after risk-reducing BSO where they incidentally have found, the pathologists, an alarmingly high rate of carcinoma in situ and even invasive serous cancer, high-grade serous cancer, the distal fallopian tube segment and the fimbriated end, and the implication of the fallopian tube in the development of ovarian cancer has led to more and more acceptance of doing a two-staged risk reduction surgically for these patients, meaning in women who are not ready to secede their ovarian function, that they have a risk-reducing bilateral salpingectomy done first, laparoscopically, at a younger age, maybe 34, 35, and then going back to do the laparoscopic bilateral oophorectomy at the age of 40. That's gaining some traction in women who, not so much for just childbearing, but just maintaining ovarian hormonal function as long as they can to avert the surgical menopause that they dread. So that's a consideration in these patients too, that we do the two-step risk reduction surgery. There's no real proven efficacious screening methodology that is reliable in doing this, keeping good surveillance on ovarian cancer patients who are BRCA positive. But the best that we've got now is doing a semi-annual, starting at the age of 25, pelvic exam, transvaginal ultrasound with color Doppler, serum CA-125. That's the best that we've got. I would say I would even do that in patients who have a strong family history and are personally unaffected, strong family history and turn out to be BRCA negative. Clearly there are other mutations that we have yet to discover that probably involve ovarian cancer pathophysiology. So if you have a very strong family historied patient, I would say this would be something that you can consider as surveillance, as it were. Let's talk a little bit more about the clinical presentation of ovarian cancer. I'm sure you're all aware of the gastrointestinal complaints that kind of skew the thinking process into that there may be something more of a innately GI problem going on rather than the GI manifestations of ovarian cancer. But bloating looms high, not the bloating that women complain about near their period, but a persistent bloating that persists for more than 2 weeks. Indigestion, they find that they can't digest their food well, the early satiety that we all know about, change in bowel habits, urinary urgency. I caution a lot of my internist friends that if women come up to them and they complain of a urinary urgency or a more vague complaint of how they void, they feel like they can't empty their bladder right, or they even will be nonspecific and say it just doesn't feel right, that they should be mindful of thinking of the possibility of this being one of the signs of ovarian cancer and refrain from the typical dipping of the urine. If it's negative, oh, you're symptomatic, I'll give you the antibiotic anyway. And this never gets better because it's not an infection. It's a sign of ovarian cancer that has spread to the anterior cul-de-sac peritoneal surface that's impeding normal urination from happening. So urinary complaints are very, very prevalent. Abdominal or pelvic discomfort or pain, usually vague, and you may or may not palpate a pelvic mass on exam. Typically you won't. But I also caution you that you need to be good about doing rectovaginal exams. I find that many residents and even attendings are not doing rectovaginal exams in patients over the age of 40. That's my sort of policy. Because you may very well feel an ovarian cancer that has sunk into the posterior cul-de-sac, which you will never feel or appreciate on a typical bimanual exam if you're just using the vaginal approach. A rectovaginal exam is essential in the patient with any complaints that may be referable to an ovarian cancer. Of course, we do the imaging. The pelvic and abdominal cavities need to be carefully imaged, and that could be done either by ultrasound at the outset or even a CT scan at the outset. PET-CT usually won't be approved unless you have a diagnosis of a cancer already. typically. Serum CA-125, imperfect, but it's the best we've got in terms of a tumor marker. And physical and pelvic exams, as I just mentioned, the pelvic exam. You should check patients' peripheral sites for adenopathy. A typical part of your abdominal exam for a patient, physical exam, I should say, is checking the groins, checking the axilla, checking the supraclavicular fossa for lymph nodes. That should be typical and just a normal part of your exam, but especially if someone is complaining of signs or symptoms of ovarian cancer. Prognostic factors. How well are you destined to do given some of the factors that we've identified that impact your chances of survival? In general, age. The younger you are, the better your chances. Stage, of course, that goes without saying. The earlier stages are very curable. A stage 1 ovarian cancer will typically have an 85 to 90% 5-year survival. Of course, as you go up in the stages, you're getting more tumor, you're getting more potential for resistant cancer cells, more room for failure. The volume of residual disease after primary debulking. The cornerstone now, and the fundamental goal is now not less than 1 centimeter, but 0. So what we call R0, residual zero disease. That's the defining surgical success story when you do a debulking. Histologic grade. You would typically think grade 1, you survive, you have a better chance of surviving. Maybe yes, but the problem that grade 1 tumor patients fall into is that their tumors are languish. They don't get cured by chemotherapy. And so they have protracted courses of ovarian cancer, living with ovarian cancer, and eventually succumb to it. Because their grade is low, the response to chemotherapy is somewhat sluggish. But generally speaking, they do last longer. And the performance status of the patient, that ties into age. The patient who is functional, active, participates in daily activities will do better. I'm not going to linger on ovarian cancer staging. You should look up the new FIGO guideline or structure of the ovarian cancer staging process that has changed in the recent years. But suffice it to say that you know that stage 1 is going to be confined to ovaries, stage 2 is going to be just in the pelvis, 3 it's spread to the upper abdomen or the nodes, and stage 4 is distant mets and includes pleural effusions and inguinal adenopathy and parenchymal liver metastases. So that's why you have to check the groins, the axilla, and the supraclavicular fossae, just to make sure you don't find any nodes there. So exploratory laparotomy is the cornerstone to the surgical approach that's geared towards debulking the patient's tumor down to an R0. There's been, traditionally it's been an open approach. Robotics has gained traction into this. So there are instances where robotically this can be done, but cases have to be individually chosen in order to ensure success. The incision should allow for exploration of the entire peritoneal surface. So if you're taking a patient into the OR and you have some suspicion, say for an adnexal mass, you have some suspicion that this may be an ovarian cancer, and I don't mean just a little suspicion, a decent suspicion where you have even engaged a GYN oncologist to be on standby. That incision should not be a transverse incision. That should be a vertical incision where anyone operating on her will have access to the upper part of the abdominal cavity. Once you get in there, if there is no gross extraovarian disease, which has probably been somewhat suspected on preoperative imaging, but you never know. You may have some surprises when you get in there, but if you open the patient up and there's no extraovarian disease, then the procedure that you're going to do is a surgical staging procedure, which means that you're going to sample predetermined places, lymph node structures, lymph nodes in the pelvis, periaortic nodes, peritoneal surface biopsies will be done, omentectomy. These are all structures that we know are favorite sites of metastatic disease for ovarian cancer. So these are either completely removed or generously biopsied, and that's surgical staging. Bulky extraovarian disease that you grossly find dictates aggressive cytoreduction, trying to reduce the patient to R0. And despite all the advances that we have in surgical technique and instrumentation, we still only achieve about 30, maybe 40% of optimal cytoreduction down to R0 in this day and age. So it's still a problem, but certainly it's, I would say this is closer to 40%. That will lead into another thing that I'm going to talk about, which is turning the tables around in terms of the strategy. Instead of operating on the patient first and giving chemo second, that we do the second first. We give chemo first and do the operating second. So that's going to be discussed in a little while. But the standard of care remains that patients with advanced disease, if constitutionally and medically able, they should undergo an initial maximal surgical cytoreduction. And the cytoreduction should be done by a well-trained gynecologic oncologist. Believe it or not, still in this country, more general gynecologists and general surgeons operate on ovarian cancers than the GYN oncologists themselves. So the problem with that is that they can't or don't make the effort to cytoreduce patients to R0 as much as a GYN oncologist would. And that is a cardinal factor in the eventual success rate for the cure of this patient, In patients who are not initially good surgical candidates, as I alluded to, and they're received by a GYN oncologist, say, with a suboptimal debulking done by somebody else, interval cytoreduction is a strong consideration. So it's been shown in a study that basically was done first in Europe that patients who have bulky advanced ovarian cancer, biopsy proven by transcutaneous CT-guided biopsy, have an equal 5-year survival, an equal cure rate if they were either primarily debulked at the outset and given chemo to follow, versus having been given so-called neoadjuvant chemo first for several cycles, typically 3, maybe 4, intervally debulked, and then their chemo finished after that. That reversal of strategy has proven to afford the same survival rate for patients. So there is a now choice that can be made in patients who come in who look like they've been constitutionally deprived by the process. And they can expect to have an equivalent success rate in being cured as the patients who are primarily debulked and may end up in the ICU with a protracted post-operative course and maybe even mortality. It's not a decision that's to be made lightly. Somebody comes in and they seem to have a lot of upper abdominal disease and we'll say, oh, we'll just give them neoadjuvant chemo. The consideration should be really rooted in finding things that maybe can't be surgically debulked at the outset. Parenchymal liver metastases, a lot of disease in the area of the biliary tract. These are things that are like deal breakers for primary surgical debulking, and patients typically are given neoadjuvant chemo in that setting. We're trying as a community, the GYN oncologists now, to kind of standardize what the findings are that would, according to like a point system that would dictate a patient, well not dictate, but basically help categorize the patient as better suited to be neoadjuvantly chemotherapy treated versus primarily operated on. And that's a work in progress where we will find some sort of a standardization that we can follow that will help us put one patient in one treatment pattern versus another. But just keep in mind that that neoadjuvant chemo with interval debulking is equivalent to primary debulking with chemotherapy to follow. The standard of care that was established in 2005 stands now that the attempt at surgical cytoreduction should be maximal. It shouldn't be a flippant, oh, let me see what I could do kind of thing. No peek and shriek attempts. The regimen of choice still stands at the combination of carboplatin and Taxol. That's a regimen that's repeated every 3 weeks for 6 cycles, typically after a primary optimal cytoreduction. I have to say, with all the things that we have done recently, in the last 5, 10 years, I should say, trying to knock out the carbotaxol standard, all these attempts have not yet been standardized alongside carboplatin Taxol or replaced Taxol, or carboplatin Taxol, and that would include intraperitoneal chemotherapy, giving carboplatin Taxol with Avastin, vascular endothelial growth factor antagonist, all these other attempts to find other regimens, combinations, have basically not been able to, in the minds of GYN oncologists and medical oncologists alike, been able to displace the primary carbotaxol. So it's still considered the standard of care, but there's some other things that we do that are nipping at its heels, so to speak. Unfortunately, ovarian cancer has a big problem, and that is even in the face of wonderfully, optimally debulked surgery, followed by chemotherapy that goes beautifully with a normalization of the CA-125 by the 3rd cycle, all these wonderful prognostic factors, still we have the problem of the recurrence issue. And that is why the majority of the patients with ovarian cancer, advanced ovarian cancer, will not achieve long-term control or basically cure of the disease. If you are left with large volume advanced disease, which is not a goal, obviously, surgically, you have about an 80 to 85% chance that you will succumb to this disease. Small volume advanced disease, 60 to 70% that you're going to die of the disease. High risk limited disease in the pelvis, your chances are much better that you're going to survive. Only a 20% chance that you're going to recur and die of the disease. And low-risk limited disease, the stage 1's about a 10% chance of recurrence and dying of the disease. When you have recurrence of the disease, basically you're dealing for the most part. Maybe I have 5 patients in the last 20 years who've recurred that have survived and been cured of ovarian cancer in the recurrent setting out of the hundreds and hundreds that I've treated. But complete responses in patients who have bulkier recurrence of ovarian cancer discovered is going to be rare. A complete response rate is rare in these patients, especially if they've relapsed within a short period of time. Treatment-free intervals are decreased every time we give another line of chemotherapy. And the median survival after recurrence, in terms of how many months they are generally expected to survive after a recurrence has been detected, is about 1 year to 2. Secondary cytoreductive surgery still has its place, even with our armamentarium of all these targeted therapies and ovarian cancer chemotherapy and other types of therapies that we use in the recurrent setting. We still do secondary cytoreductive surgery. And we have to be careful who you're going to choose, because this is an all or nothing deal. If you go in as the surgeon and you only remove half of what you see on the CT scan, half of the recurring cancer, it's as if you remove nothing. So patients who are sent to the GYN oncologist for excuse me, secondary cytoreductive have to have features to the cancer that would be encouraging to the surgeon to say, yes, I think I can go in there and get it all out. Because if you don't, it's as if you did nothing. You also have to have demonstrated that the tumor has been previously responsive to chemotherapy. If the patient didn't respond to chemotherapy and eked out a complete response somehow, eventually, with a lot of trouble, and then the cancer came back, and we know that it was very difficult to treat in the first place. That does not bode well for what's come after a cytoreduction. So that should be a feature of maybe deciding against it. If the patient has had a long progression-free survival, a long remission, as it were, more than 1 year, that's positive towards doing a secondary surgical cytoreduction. Performance status. How the primary cytoreduction went. Did it go well? Was it an optimal cytoreduction? Where are these tumors? Are they regionally located, accessibly removable? Is there no ascites? These are all features that come into the denominator when you're determining the factor here, the fraction of whether you should do a cytoreduction or not, because you have to be mindful the patient can succumb to complications after a cytoreduction. What we used to call salvage chemotherapy, there's no better word for it. You're not real, well, there is a better word for it. It's just, I guess palliative chemotherapy. Salvage is the old word, thinking you're going to salvage the patient. Typically, you're not. These are all the agents that we use in the setting of primary ovarian cancer, recurrent ovarian cancer or persistent ovarian cancer. And that would include the usual, the platinum, taxanes, doxorubicin, topotecan, some oral agents, hexamethymelamine. These are all, even tamoxifen, you'd think it has no place in the treatment of ovarian cancer because it's not really an estrogen-dependent tumor, but it has a very good response rate, and surprisingly so, to the degree where you can actually rely on it as a line of therapy higher up in the totem pole rather than delegating it all the way down to the 6th or 7th line. Oral etoposide, gemcitabine. And I would say now, as I'll allude to in a little while, something called a PARP inhibitor. And there are 3 PARP inhibitors now available to us. So the PARP inhibitors are another therapy, not chemotherapy per se, but a therapy we can use in the recurrent setting. In determining how you're going to treat patients with chemotherapeutically, you always have to keep in mind that you're dealing with a palliative setting. You're dealing with trying to balance quality of life for these patients in addition to trying to eke out as long as a survival with quality of life as you can. So it's not so much what agent you use, because they're all pretty much in the same category of response rate. You can pretty much dichotomize the response rate to platinum sensitive, being on the order of about 10 to 20%, and platinum resistant, 10 to 20%, platinum sensitive, 30 to 40%. Sensitivity to platinum is determined by whether you recur within 6 months of having finished your chemotherapy at the outset, or whether you recur after 6 months. So if you recur within 6 months, that's platinum sensitive, and if you recur outside of 6 months, that's platinum resistant. And platinum sensitive, actually, I think I may have said it backwards. Platinum sensitive is if you recur after 6 months, and platinum resistant is if you recur within 6 months. So the platinum sensitive patients do well overall on all counts. They are more sensitive to the chemotherapy that's given to them. They have longer survivals. They're more amenable to the successes of targeted therapy. The platinum-resistant ones, the ones that recur within 6 months, have a more dismal prognosis, don't respond as well, don't do as well. So when all these drugs are pretty much on the same level response rate-wise, it's not so much what you use, but how you use it given the patient's medical morbidities, proximity to the chemotherapy unit. All sorts of factors go into the decision-making of how to treat these patients after they fail their primary chemotherapy. I'll skip that. I'll skip that too. Radiation. Radiation therapy doesn't come to mind when you're talking about ovarian cancer. And it's not because radiation is not a good treatment for ovarian cancer, that ovarian cancer doesn't respond to radiation, but it is the circumstances with which the patients recur that pretty much preclude the ability to give radiation. Radiation is no longer given to the entire abdomen. That was a technique that was attempted, toyed with, held on to for many years. And the toxicity and the morbidity associated with whole abdominal radiation, which is what you would have to consider if you had patients who had recurrent ovarian cancer in the upper abdomen, lower abdomen, is just so fraught with morbidity that it's a technique that's gone by the wayside. But if you have, and I have in my own practice, had patients who, interestingly enough, for whatever reason, have recurrent cancer, ovarian cancer in the pelvis, and the patient really doesn't want any more chemotherapy. Maybe she's had a hard time with previous regimens. Radiation therapy is fair game in treating ovarian cancer confined to the pelvis in this recurrent setting. And I've had personally some success with these patients averting the need for chemotherapy. And I've never had anybody be cured by it, but it works just as well, if not better in some circumstances, with chemotherapy. So it's something that if you're asked about what is the place of ovarian radiation therapy in ovarian cancer, it's in patients who have recurrence, disease, who may not tolerate chemo well or not want chemotherapy, and the disease is confined to the pelvis. Next to the problem of the early detection, the lack of early detection in this disease, the relapse rate really defines the morbid course of events with these patients. So it's fraught with two problems: the high recurrence rate and our inability to really detect ovarian cancer in the early stage reliably. What do we do with patients after we've given chemotherapy? This is where the new PARP inhibitor and the use of Avastin, the VEGF, the VEGF inhibitor, comes into play. What do we do after chemotherapy? It feels inadequate, but we sort of just cross our hands and sit on them and stop and observe these patients and hope that they're going to be one of the ones who are not going to recur. Again, the general recurrence rate being in the 70 to 80% risk range for advanced disease patients. It's something that affords them the most quality of life, especially if they are probably going to recur later. You are affording these patients, by stopping and observing them only, some time of quality of life that is going to be important, because they are going to lack some quality of life once the recurrence happens. We have no proven benefit in terms of overall survival in giving patients any more drugs in the maintenance setting. That may change as we explore more and more the use of PARP inhibitors or other agents that are coming down the pike. But again, you have to be mindful. Here is where the GYN oncologist and medical oncologist has to really consider the quality of life of a patient who has a very high risk of recurring. Performing second look surgery. That may be something I might remember, maybe more of you youngins don't, because in the 70s and in the 80s, there was this practice of going in a second time and doing so-called second look surgery. And it should be of historical importance, just so you know this. We don't do it anymore, but in certain settings. After the patient would be debulked surgically, have her chemotherapy, and reach a point where by all parameters she seemed to have been completely ridden of the disease. Her CA-125 was normal, her physical exam was normal, her imaging was normal. Surgeon, GYN oncologist would go in yet a second time and do a exploratory surgery, biopsying upwards of about 30, 40 things, lymph nodes that were left behind, portions of the omentum that were left behind, peritoneum, adhesions, to see if, despite the clinical response being complete, there may be some persistent microscopic or pathologic disease, which would then prompt the giving of more chemotherapy when the patient was clinically well. This would be the so-called consolidation therapy. Or even in those instances, they used to give abdominal radiotherapy. We do that now only in the instance of doing clinical trials, where we are testing out new primary chemotherapeutic regimens, seeing what the pathologic response might be, or establishing what the pathologic status of the patient's disease is as they embark on the new chemotherapy or some other type of ovarian cancer therapy. There's very little a reason to do a second look surgery now. I mean, we did it laparoscopically even for a while. But what really made us not do the second look surgery was when the paper came out showing that patients who had a complete response and had a second look surgery found to have pathologic persistence of disease and then got more chemotherapy, they lived just as long as patients who had primary surgery, chemotherapy, were left alone, and were treated when their disease clinically manifested in the future, when their recurrence clinically manifested. So this preemptive strike does not work. They live as long. The only difference is the second look patients, unfortunately, had less quality of life because they got all that extra chemotherapy. I'm going to skip these things that show pluses and minuses in doing something active versus not active in the setting of a patient who is clinically free of disease. I should say here, that it is very important to understand the psyche of the ovarian cancer patient. We unfortunately cannot offer the patient the words, "you will be cured," when the cancer comes back. We skirt around these words. We say things like, oh, ovarian cancer is a disease, a chronic disease, a manageable chronic disease. Patients don't want to hear that they have a chronic disease. They want to hear that they are cured of the ovarian cancer. And we don't have currently a curative therapeutic modality where the vast majority of the patients with ovarian cancer will be cured. There are a few very lucky ones, as I said, but the thing is, the chronicity of the disease is something to be considered because we know it can be chronically managed. We have patients living longer and longer, and the significance of that is that they then have the ability to be exposed to or treated with new agents that are coming down the line, that they will eventually receive most of the agents that are active in the treatment of recurrent disease. And the patients who live the longest are the ones who are able to, and they're the lucky ones, who are able to tolerate these treatments. And the future directions that ovarian cancer treatment is taking is cognizant of that. I would say dose intensity is still something in the works. We are using intraperitoneal chemotherapy. We are using weekly chemotherapy to intensify the dose of the medication that is that the cancer is exposed to on the peritoneal surface. The IP chemotherapy regimen is only something you can give to somebody who's been optimally debulked in the primary setting. But it's been used even in recurrent settings, maybe after a secondary cytoreduction where you get down to R0, you can expose the patient to IP chemotherapy. It has not been universally accepted. It is not the standard of care yet, but it has its successes. It has been shown in several papers that it provides the patient a longer overall survival. The same thing with dose-intense IV chemotherapy, where we give it weekly. We don't let that dip in the blood concentration of chemotherapy happen. We constantly slam, so to speak, the ovarian cancer with the chemotherapy. These have been found to be, in some instances, better, in some instances not. Biological agents, tyrosine kinase is something that looms big in the treatment of lung cancer. It's starting to gain some traction. It's been looked at in ovarian cancer, monoclonal antibodies. But what I thought I mentioned in here, and what I should mention is the PARP inhibitors, specifically PARP inhibitors. The simplest way of thinking of how PARP inhibitors work is, cancers develop from genetic mistakes. Single and double-stranded breaks in the DNA in the cell will lead to the production of a malignant cell, or the development of a malignant cell. Single-stranded breaks are not lethal. They can be repaired, and the enzyme that repairs single-stranded breaks is the PARP enzyme. It's the poly-ADP ribose polymerase enzyme. And if you inhibit the ability of the PARP enzyme to repair a single-stranded DNA break, then it becomes a double-stranded DNA problem. And if you impair the ability to repair the double-stranded DNA break, and that's where the BRCA1 and 2 proteins come into play, then the cell dies. So the PARP inhibitor prevents the repair of a single-stranded DNA break. It evolves into a double-stranded DNA break, and if the patient has BRCA1 and 2 problems, they have a mutation, the cell dies. That's why PARP inhibitors are so much better in BRCA1 and 2 positive patients, because the BRCA1 and 2 is not there to salvage the situation of the double-stranded DNA break. So we find that PARP inhibitors can cause complete responses in patients who are BRCA positive, but surprisingly so, will do so even in patients who are not BRCA positive. So these PARP inhibitors have now been, in the last 2-3 years, the new kid on the block in the treatment of ovarian cancer. There are 3. They inhibit PARP1 and PARP2. There are 17 PARP enzymes. And we are getting surprisingly long remission rates with the use of these drugs that are being employed in the setting that we normally would stop and observe. That setting of stopping and observing is now being compromised, if you will, or changed. I wouldn't say compromised, I would say changed by the use of PARP inhibitors. Keeping patients on these PARP inhibitors is causing the eventual recurrence that the patient is destined to have to be further and further away. The last one, the PARP inhibitor that recently was FDA approved, and you don't even have to be BRCA positive to get it. It's called Zejula, Zejula. That has afforded patients a 20-month disease-free interval or remission compared to patients who were being stopped and who were just being observed. That was a 5-month progression-free period of time. So patients who were taking this PARP inhibitor deferred the recurrence of their cancer for 20 months compared to patients who were just being observed. And that's an astounding statistic, but has yet to be transformed into improvement of overall survival. They may have a longer remission rate, but they may, once they recur, not live as long anyway. So the problem is we don't have anything that really changes the overall survival other than Avastin by a few months, and that's been included in primary ovarian cancer chemotherapy and in the recurrent setting. But what you should be mindful of is the orally administered PARP inhibitor, which causes nausea, vomiting, weakness, some bone marrow suppression, but it's going to gain a lot of traction in the armamentarium that we have against ovarian cancer, still making it a chronic disease, which patients don't want to hear, but it is very encouraging that it may translate into something more. So tumor vaccines still in the works, interferons, proteomics, these are tests, the proteomics looking for changes in the protein array in blood as a potential for early detection of ovarian cancer, preclinical detection. Lots of directions we can go, but the one that we are most proud of right now and hinging on to, because it gives GYN oncologists and medical oncologists something to work with other than the typical chemotherapy, and even the Avastin has outgrown itself, is this new PARP inhibitor age. And we should be seeing more and more, my lecture will probably be very different next year, as we see more and more targeted therapies being used in the treatment of not just ovarian cancer, but lots of cancers. Okay, thank you very much for your attention, and I'll take any questions. Who? Oh, sorry. Morning. Right. I don't know the answer to that, and it may be because there is no answer. The implication of IVF, as you well know, as they stimulate ovarian function to garner more and more eggs, that was really a hot topic as IVF exploded onto the scene, more so in the 90s. It has sort of fallen by the wayside. I don't think it was ever established really that the IVF or the reproductive assistance efforts in trying to get patients to stimulate patients' ovaries to enhance their risks or their chances of getting pregnant has ever been solidly implicated in the pathophysiology of ovarian cancer. It was suspected when you get some of these anecdotal stories of someone just having IVF and then 3 months later she's diagnosed with ovarian cancer. We've studied it, it never solidified, so I don't think it's something that really people think about per se as they're planning to try and get pregnant if they're like 40. I would say though, some caution would be good to be exercised, maybe more surveillance, paying more attention, maybe more ultrasound surveillance in patients who have really a terrible family history. I would keep a closer eye, but to say you can't have IVF because you have 2 family members in the past that had ovarian cancer is not going to be something that's going to be said. But I would say watch that patient more closely. And there are no limitations as to how many cycles. Nobody knows the answer to that. Yeah. Uh-oh. Right. Thank you. Okay, thanks very much.
All right, if everyone will take about a 5-minute break to be back here at 10:10 for our next lecture, which is Dr. DeLuel.